Welcome to Taking the Pulse, a healthcare and life sciences podcast. I'm Tina Emerson, here with Maynard Nexon healthcare attorney Matthew Roberts. Good to see you, Matthew.
Good to see you.
Today we are joined by Jane Pine Wood. She is the Senior Vice President and Chief Legal Officer of BioReference Laboratories, a laboratory offering expertise and innovation in oncology, urology, and women's health. Jane, thanks for joining us today.
Thank you very much. Happy to be here.
Well, you are one of the most well-known lawyers in the clinical laboratory space and have a national reputation for great work in this area. How did you first get involved in healthcare law, specifically in the clinical laboratory space?
Very, very happenstance. I was a second-year associate, and this is going back, I would have been in 1988, late 88, 89. And one of the partners in my law firm was going to give a speech for the American Pathology Foundation, had a death in the family, handed me, I was doing real estate work. He handed me his plane ticket, his speech. This is in the days when you could take anyone's plane ticket and jump on a plane. And I had about a 5-hour plane flight to read his speech and try to learn about clinical laboratory. I have to admit, I knew nothing that I was talking about. I gave the speech, and after the speech, people came up and said, "Oh, can you speak at our state conference about this? Can you talk about that?" It was also very fortuitous in that, so again, I knew nothing about clinical lab other than the speech I was reading. But that same year, CLIA 88 came out and the Stark Law came out. So it was a wonderful opportunity for me at the ground level to say, well, here are these two new laws. Particularly for a woman in law at that point, where I would have to be very gray haired with a lot of wrinkles to be taken seriously in real estate. Here was an area, a new area of law where I could learn something, and no one else knew it either. We were all learning. So I was able to get in many ways on the ground floor.
That's great. Well, I've had the pleasure of working with Jane over the years, and she's been great to work with. So I didn't know that story, so that's very interesting. Well, let's talk a little bit about the growth of clinical laboratories. We know that due to COVID, clinical laboratory services have exploded because of the need for dealing with this pandemic. Can you tell us a little bit about you and how BioReference responded to the challenges of COVID, and particularly the ever-changing regulatory framework that was in place as the pandemic evolved?
Certainly, and it probably the most fascinating part of my career. Obviously, a very tragic events of the pandemic, but from a legal standpoint, fascinating. At BioReference, we are in Bergen County, New Jersey, just across the Hudson River from New York. And Bergen County was, the second big epicenter of the COVID outbreak. So at the time when the country is starting to close down, we're looking at what's happening. We are also being hit very hard, very early on among our own workforce with COVID as well. So we had a bit of a double whammy. Because we had employees who were very quickly getting sick, as well as our clients who were seeing patients come down with these horrible, flu illness at first, weren't quite sure what it was. We had to just make a decision. Do we invest to bring up COVID testing? I'm also a member of our senior leadership team. And it really was a significant decision because we ultimately ended up investing tens of millions of dollars in the equipment to bring up COVID testing. But at the point when you're hearing that things are starting to shut down, hospitals are going to stop elective surgeries, doctors are shutting down offices, we are faced with an immediate drop in our test volume, immediate drop in our revenues. At the same time, do we invest to bring up testing in something that might be gone in a week or two? And if we go back and think the early days of the pandemic, we had no idea how long this would last. We ultimately decided to flip a coin. At the time that we were actually furloughing a quarter of our workforce, furloughed about 1,000 employees, soon, probably that was March, April of 2020, we decided to make the investment. Our then president, Dr. John Cohen, had a lot of connections with the state of New York, with the governor's office, as well as with the state of New Jersey. And so we very quickly decided to move in and to assist the state, the city of New York, state of New Jersey with COVID testing, given that it was the epicenter. And that was our focus. We were one of the first laboratories to begin drive-through testing. But you start to think of what are the legal issues. I mean, we all know for those who work in the laboratory area, you need a physician order. All of a sudden, we're working with government agencies who are saying, it's a pandemic. What's going on? What do you mean we need a physician? Who's going to order this? Whereas a laboratory is saying we have to give results to an ordering physician as well. How do you set that up? How do you get results back? For the ordering physician, what is he or she going to do with those results? I had a lot of conversations with legal counsel for the governor of New York, for city of New York City, as well as other states as we started to expand the government testing, to talk through these issues of, do we get a laboratory director for the Department of Health, for example, to order testing for these drive-through or pop-up centers? How do we get the results back? Again, if you think about a physician who may be with a state Department of Health, they're not used to receiving via an EMR test results. They may be receiving data that laboratories send from an epidemiological standpoint, but not patient results. And how are those going to be triaged? So there was tons of work behind the scenes to try to mesh the requirements of CLIA, CAP, those states that have their own reporting requirements, with the expectations of state, county, city agencies asking, what do you mean you need a doctor? Patient just can't walk through and get a test result. Those were very, very interesting.
Yeah, I giving advice from the outside counsel perspective to clients on that, particularly in the area in New York, New Jersey, it was very complicated. And you were the provider, and so I know it was more complicated for you. Hopefully, your work schedule has gotten a little more sane, because I know you were working crazy hours during those times. As a result of COVID, there were there's been an increase in of new companies operating in the clinical lab space, startups, if you will, not as mature and as experienced as BioReference, much smaller, but doing similar work. Can you talk a little bit about the impact of those new players in the market? Because I think that's been something we've been dealing with and seeing how to advise some of these folks, but it impacts the market in other ways too.
Certainly does. And I would say, to your point, there are certainly very dedicated, legitimate people who have started smaller laboratories who moved in to fill what was a dire need at the time for COVID testing. And I think we would all recognize there are a number of fly-by-night people as well, who are not traditionally from the healthcare area, but also may not have had legal advice or the experience to know what a highly regulated area this is. So to some extent, we were at a competitive disadvantage. I mean, we go and set up a testing site. We work with the state of New York or the state of New Jersey or wherever we were to get a permit, because most states do require a permit. Depending upon what state we're doing the testing, there may be requirements for certain licensure or certification of the individuals who are taking the specimen collection, all those requirements. And what we were encountering were potential clients saying, well, why should we go with BioReference? And it's taking a little more time. You're making us go through all these hoops, and so will just do the testing. I had to spend a lot of time explaining to people that these really are important rules. The pandemic didn't mean that all these regulations went away. We all know as lawyers that many states did reduce the regulatory impact of a lot of regulations during the pandemic, and a lot of that's gone away now. So we certainly had a lot more flexibility, but didn't mean there were no rules. But probably the single biggest issue is with respect to billing for testing. As a general matter, a laboratory or any healthcare provider can only bill a third-party payer for any healthcare service, including laboratory services, if they're medically necessary, if the ordering clinician has documented medical necessity for that test. Whereas we know, during the pandemic, certainly people who are symptomatic, okay, fine, there's medical necessity, you're symptomatic, you want to make sure if you have COVID or not. But then there were lots of people saying, well, I'm going to go home for the weekend and see grandma, or I'm going out to some sporting event and they're going to require me to have a COVID test before I go. It was the desire and the request for us to bill insurance for that testing that I would say was a competitive disadvantage for us, because we took the position we were not going to bill insurance for testing that was not medically necessary. We were not going to bill the HRSA fund for testing that was not medically necessary. That put a lot more burden on us. in terms of ramifications, and I'm sure some of your clients have seen the same thing, many payers later have gone back and they are monitoring, they're auditing the records they pay for, and they're finding that a lot of testing was not backed up by documentation by ICD-10 diagnostic codes to support the medical necessity. So on our end, what that means is we're dealing with a lot more audits than we would have had typically, because we are caught up with payers who are doing a shotgun approach and auditing all laboratories to make sure there was the medical necessity for the COVID testing. Certainly a little bit more challenging, with the COVID testing. A lot of clinicians who would not have been our typical clients, came to us to perform testing. At the height of the pandemic, we were doing about 70,000 RT-PCR tests a day, in addition to point of care testing. So certainly a high volume. And as anyone knows who goes through the audit process, by the time you have to go back to clinicians and get medical records, et cetera, to support audits, it can be very time consuming. I think that all of us will be dealing with the ramifications of those audits for quite a while.
And over the duration of COVID, a lot of technological advances have happened. And how do you think that those changes have impacted clinical and reference lab work for you?
One of the areas that we saw was in the advancement of point of care testing, in that, there's always been point of care testing in nursing homes or hospitals. But I think for most people, you weren't used to going to some pop-up clinic somewhere and getting the testing done. We moved in early on in the pandemic. In addition to doing a lot of testing for healthcare providers and for governmental entities, we also did the testing for the NBA. We did the NBA bubble as well as the NBA testing. We did the NFL. We did Major League Soccer. We did NHL. We did women's NBA. We did a lot of the Olympic testing. So we moved very much into the sports realm. And a lot of that was point of care. But what you realize is, again, you have to report results. So you have these handheld point of care testing devices for COVID, but not only do I have to report results to the ordering clinician, during COVID, the states all want, usually daily, reports of the testing. So we're having to, our IT department is put together de novo programming to be able to deliver results in ways that we've never delivered before. And the other way, I think, just honestly, is it accelerated telemedicine across the board, in that patients want to be able to have the convenience now that they've gotten used to having so many things done at home, and including a lot of people doing self-testing or going to down the street to have lab testing done. They're looking for that same kind of convenience. And that's one of the things that we're struggling with now and working with our clients in order to deliver the convenience that patients have come to expect now.
Yeah, the expectation is definitely different. You going back to something you mentioned about audits, as you know, having worked in this space for a long time, the clinical labs have been the target of various regulatory investigations over the last, really for decades. Talk a little bit about why that is, why clinical labs tend to get a little bit more focused than other healthcare providers, and then how you manage the risk of that. And now that you're in-house and you deal with that regulatory risk, in addition to the audits as well, because those are going to be sort of the nature of dealing with payers.
I think there are a couple of reasons for the laboratory. One of them is, which I alluded to earlier, is it's a relatively low bar to entry. Mm-hmm. A non-physician is not going to open up a medical practice, for example, but I, as a lawyer, could open up a laboratory as long as I've contracted with someone to be able to serve as the laboratory director, and I can do fairly minimal testing. I could even get a CLIA moderate complexity license, not that difficult to get. Because it's a low bar to entry, and there are other segments of healthcare which have been similar in the past, durable medical equipment would be an example, home health at times, where my experience has been there is a higher percentage of perceived abuse, whether or not there actually is, but a higher, payers tend to view this as having more abuse because you do not have someone who may have gone through the discipline of being trained in a healthcare environment, understanding what the rules are. Or for someone who truly is a bit of a shyster, it's a little bit easier to get in because of that low bar to entry. I think the other difficulty we have, though, for most ancillary services is we don't see the patients and we do not have access to the full medical record. So we are completely dependent upon the ordering clinician to attest that the testing is medically necessary. We have to rely upon what the doctor puts in the requisition in terms of billing insurance, the ICD-10 code. We hope that the ordering clinician has patient records which document that medical necessity, but it is rare for a laboratory, and again, other providers of ancillary services have the same issue. It is rare for us to know if that medical necessity documentation or other eligibility criteria required by payers actually exists in the medical records until after we're audited and we've requested it. And that's when many times we're finding out for the first time, oh, this is an excellent medical record, we're golden, or,
Ouch.
this doctor has very, very skimpy notes.
Let's talk about EKRA for a second, because it is another challenge that labs have had, and it's been out for 4 years. And its application to some of the work that labs do has been a serious point of challenge for folks who do regulatory work like yourself and others, guiding labs on how they can market their services and get their work, because now the EKRA law challenges some of the ways that historically the anti-kickback statute has allowed. So what are your thoughts on the lack of clarity or inconsistency, from about EKRA's safe harbors and inconsistency with the federal anti-kickback statute?
It is very problematic, and certainly with my colleagues who are at many of the other national and large regional laboratories, the in-house council, we certainly share our struggles with this law. There's certainly initiatives going on at a number of levels, going down different pathways to try to get some clarity in the law. What is difficult is because, precisely as you said, we have this conflict between what I would argue is an exception under the anti-kickback law for employment relationships.
Absolutely.
But I have language in EKRA, which of these is supposed to take precedence? It's also troubling to me that for those who've delved into the history of EKRA, laboratories weren't even included until the 11th hour.
The last minute.
Statute, very last minute, and without an opportunity to really provide a comment. We were not really part of that notice and comment. I think this is one of those that the baby got thrown out with the bathwater. I understand why there was a concern regarding laboratory testing, but I don't think labs were the evil that was necessarily targeted by the law. I'm certainly very supportive, and with many others working various avenues to try to see if we can get some clarity in this area, because otherwise what will practically happen is it's not just healthcare, it's not just laboratory, but most people who are in sales are going to be incentivized with commission or variable payment. And most people in sales are not going to want to be working for fixed salary or discretionary bonuses that are unpredictable and at the discretion of the employer. Makes it very difficult.
I agree.
Well, Jane, I have one more question for you as we close, and that's, what piece of advice would you give to outside counsel who is looking to help clinical labs navigate and succeed in this space?
I think what's been very, very helpful for me has been an informal network that the Council for Laboratories have put together. When I went in-house at BioReference, colleagues who I knew at LabCorp and Quest called me up my first week of work and said, why don't we put together our own little in-house group of lawyers, our support group? We can share ideas. We can talk about challenging issues such as EKRA, basically support one another. And some people may think it's rather odd. Why would these competitors, why would their lawyers be getting together to share tricks of the trade? But the answer is, it is an extremely competitive area. And if we can have a level playing field from a legal standpoint, if we can ensure that we are all acting appropriately in compliance with the law, then our commercial teams, our laboratory teams, they can compete on quality, turnaround time, all those things. And that's all fine and that's appropriate. But none of us want to have to be competing in an unlevel playing field from a legal compliance standpoint. So I would say anyone who,
Yeah.
it's a great group we've put together.
Right.
It makes perfect sense. It's great to have that support. Well, I thank you very much for taking the time to be with us today. Great insights. We really appreciate your time, Jane.
Oh, thank you. Enjoyed it.
Thanks very much. We'll see you next time on Taking the Pulse.